Oh. She provides supportive psychosocial oncology services to people with intellectual and developmental disability who have cancer. She also works on systems improvement to remove barriers that produce inequitable cancer outcomes. In her prior roles, Melissa provided counseling to transition-age youth with intellectual and developmental disability in the Newton Public Schools Community Connections program. She also worked alongside disability self-advocates to develop advocacy and mental health curriculum for youth with IDD in the Youth and Young Adult Empowerment Leadership and Learning Lab at Boston University. Melissa is a former Boston Children's Hospital Lang Fellow. Welcome back. Hey. And welcoming Jonathan Gardner. Hey, John, welcome back. Yes, John. A dedicated advocate for disability rights at both the state and national levels, a homeschool graduate, cancer survivor, an individual who happens to have autism. Jonathan serves as an official ambassador for Operation House Call through the ARC of Massachusetts, a Flutie Fellow for the Doug Flutie Jr. Foundation for Autism, co-chair of the Massachusetts Supported Decision-Making Coalition, and a board member of Massachusetts Advocates for Children. Jonathan believes, this is a direct quote from him, as human beings, our differences enrich each other. Our voices together can be powerful and significant. We should all strive to create a world where everyone's voice is heard and every life is valued. Amen. Welcome back. Looking forward to your talk. The floor is yours.
Good. Thank you all so much. Really amazing to be back here and be like in this role. It was such a really pivotal experience being a LEM fellow. So I'm really happy to be back and happy to have Jonathan and all his wisdom. Okay, so we're going to talk all about cancer care for people who have intellectual and developmental disabilities. We're going to hear some lived experience. We're going to hear what we're working on at Dana-Farber to really improve the system and improve supports. We got a big intro, so I guess we'll skip our written intro. But our objectives for today are to explore with you the health inequities that are experienced by patients with intellectual and or developmental disabilities, and to be sharing best practices, some examples of psychosocial programming for cancer patients who do have IDD. A little bit more agenda-wise to show like all the different tabs that are open in our brains. It is a lot of content, so some of the examples of content are just a quick cover of what is disability, disability intersectionality. We're going to then dig into the inequities and the barriers to care. I want to share some examples of how we're looking at disability identity and accommodation screening at Dana-Farber, some of the assessments we're piloting, and lots around clinical and psychosocial considerations. May I write Jonathan?
Yeah, I'm on slide 5.
Awesome. So what is disability? I know that you are all deeply in this. You care about this personally, professionally. I'm sure that you've gone over it many times in LEN. So we're not going to take too much time on this, but what I want to emphasize is that at Dana-Farber, we're working with our patients, both from patient advisory council and also disability community members, to help the medical system understand what is disability and to not be solely viewing it from this medical model and more pathologized model. We're trying to really shake things up so that folks can see it from the social model of disability and can really be thinking about the interaction between a person's disability and the environment. And imagine being at a cancer hospital or coming in for treatment. And we're going to hear all about later from Jonathan, like the sensory experience, the overall experience of what that's like and how that in itself impacts care. So developmental disability, I know you all know about this, intellectual disability. I'll use the acronym IDD to kind of keep us moving along. And next I'm going to pass to Jonathan.
The words we use to describe people with disabilities really do matter. All people are multidimensional. Some words I want to provide definitions to. Okay, I didn't know this was one of those. I didn't know if it was just one of those things. But no divergent. The the natural vibrations in how people's brains work. Oh, excuse me, variations. My apologies, I didn't sleep last night. Neurodivergent, a person whose brain works differently from what is considered the norm by society. Neurotypical, a person whose brain works in the way considered the norm by society. However, we recognize that typical does not mean better, and we celebrate each person for who they are. Neuro-inclusive refers to an inclusive environment where neurological differences are acknowledged, celebrated, and accommodated.
Jonathan?
And I'm going to say, swing it back to you. I thought it was going to be like best slide for a second.
So many animation.
Yeah.
And with the definitions that Jonathan just shared, so we have tapped into the perspectives of our patients and the disability community, again, about like what language should we be using, can we be using to help medical professionals, both direct patient facing and non-patient facing, and having some understanding of neurodivergence and how we can better support both our patients who are neurodivergent as well as staff members. But here's where we have some cool animation. So I'm guessing that you've covered this maybe earlier this year in LEN, the idea of multidimensionality, intersectionality. When it comes to cancer care, what I've been working on in trainings and in really consulting with the medical teams is just see each person as a whole beautiful person, and disability intersects like across the board with everything, race, ethnicity, gender, sexuality, and more. It is like one piece of a much larger puzzle. And when people have multiple identities where they may be marginalized by the system, then the oppression that they feel is like compounded. So we're trying to help providers and the system really understand this and to think more about the communication and learning. So in the cancer care world, especially for adults, communication and learning is not one of the like basics in assessment, but we're trying to weave that in when we're getting to know a patient and we're thinking about how they are best going to learn really complex information and how we can best be assessing how they're doing in their cancer care. So as a social worker and in this programmatic lens, we've been weaving this in when we have patients who have intellectual and or developmental disabilities. And then what's really cool, universal design for learning, this has been helpful for so many other patients as well. And some other key pieces I won't get too far into because I know Jonathan's going to cover some of this in a couple months around decision-making, but helping the medical community understand what are the differences in independent decision-making, supported decision-making, guardianship, service-ship, etc. And one last piece is when it comes to independence, doesn't mean somebody has to be independent in every single aspect of life. We all have strengths. We all have challenges. That is like so natural to us being human. Forward. Okay, so a bit about the research. There's not a ton out there. This is definitely an unmet field. Perhaps some of you may be able to jump into this. So I do have some citations that have been in the last few years. If you look at cancer patients who have intellectual and or developmental disabilities, and you compare them to folks who don't, people who have IDD are being screened for cancer at lower rates. When they are diagnosed with cancer, they're being diagnosed at more advanced stages. They're experiencing delays to treatment. And it's not only a delay to get treatment started, it could also be delays throughout the course of getting their regular scans done, having blood draws done. There have delays like across the course of their treatment. There's an increased chance of adverse medical events or pain management. And then there's also the greater likelihood that people who have IDD are dying from certain cancers. In particular, what's been studied are breast, lung, and colorectal. So like, to me, this was really shattering, and reading about this and having supported some students and families who were experiencing cancer, that's what pivoted me from being in the school system, which is where I ended up after LENS. So going from the schools to then being in a medical system and trying to say, okay, what can we do here? Okay, I'm gonna pass back to Jonathan. You do this animation that you're doing.
Okay, that's it. Now let's get into a little bit about, well, me, aka one of my favorite topics. So when I was diagnosed with cancer, I was 18 years old. And when I was trying to figure out what was going on with my leg, many healthcare providers tried to figure out why I was having pain in my leg. There were a few medical professionals that dismissed me because they saw me as autistic over a human being in pain. They did not talk to me even when my mom would redirect them to me. One even told my mom to bring me to a psychiatrist. It was not until we found a doctor who looked me straight in the eyes and told me she did not know what was wrong with me, but was going to find out. She listened to me and validated my concerns, which built trust with me. And she was the one that got me the MRIs that eventually led to a biopsy and confirmed I had Ewing sarcoma, which is a rare form of cancer. I was treated at Massachusetts Regional Hospital Sarcoma Department in Boston, Massachusetts. I've been consultant with Dana-Farber's Neuro-Inclusive Program as they develop their special care for people who happen to have IDD. Fast forward, and about a year ago, I was having a lot of stomach issues that were caused by the radiation and chemotherapy I had. I was scheduled for an endoscopy. Days before the procedure, my mom received a call saying it needed to be rescheduled at a hospital instead of the clinic it was scheduled at, and that this could take months to book. When asked why, the clinic said, Jonathan is autistic and his behaviors are concerning. But when my mom asked what behaviors, they admitted, we're not sure, but he doesn't fit the criteria of our center. The truth is, there were no behaviors. In fact, the doctor who recommended the procedure described me as a pleasant young gentleman. Yet because of my autism diagnosis, assumptions were made rather than me being an individual who has every right to the same exact and timely care as people who are neurotypical. This is ableism, being judged and excluded based on my disability and not for the person I am. Even if I did have behaviors, I still deserve to have equal access to care, no matter my ability, because everyone's life matters. I should not have been denied the health care I needed because I am autistic.
And
Now back to my phone.
one time is one time too much, and I can't even count the number of times that I've heard very similar stories when it comes to having preventative care scans done, and even when people are in treatment. Thank you, Jonathan. Okay, so back it up now a little bit about disability identity and accommodation. So more than 1 in 4 adults in the U.S. have disabilities, and an estimated 1 in 20 have IDD. So that's like 3 to 5% of the population. And at Dana-Farber, about a year ago, we rolled out some new screening questions where we're now systematically asking about disability identity when we are registering new patients. Previously, there were no particular questions about disability, about even accommodations. It's something that the person disclosed, great, they would have it, but it wasn't being asked. So this was an area that we really dug in programmatically, systems-wide, last year, and it's so important. We need to know before somebody's coming in, how can we best support you? How can we make sure that we're going to provide you with a timely and successful visit on the system and for us to be addressing that? So we now have some standard questions that we're asking at registration, and we're also building in more frequent touch points because, as you know, disability is also dynamic. Disability can occur at any time. And when you're in cancer treatment, there's also many disabilities that are secondary to the cancer and or to the treatment itself. So for accommodations, when we're talking to patients about it, We're thinking about physical accessibility, the medical equipment, making sure that we're getting them in the right room, all the communication, learning, policies, practices, and more. Okay, so the program that we developed at Dana-Farber, and again, it's very new, like we just rolled it out last year. We have an initial assessment to really get to know the patient as a whole person. And that information then helps social workers on the social emotional lens, and it really informs the medical teams, people that are also behind the scenes doing scheduling to make sure that we are providing the most accessible, the most supportive care, and the just right kind of support. So for the assessment, we did some piloting, working with folks from our patient advisory council who have disabilities around what are the questions that you wish people were asking when you're getting ready to come in for care? What's the information that would be most helpful for your team to know about you? So we broke it up into different topic areas. You focus on communication, expressive, receptive, learning styles. We also want to know, is it helpful if we have a scribe, an audio recorder, if we're making plain language stories, like how we can best support each person? Decision-making, we shared a little bit about that earlier, really, really important to know about decision-making and to break some of these ableist perspectives that are ingrained, where people may assume somebody has IDD, oh, they're not making their own decisions. So we talk about decision-making, personal strengths, interests, because that can really tie in and support someone in treatment, especially if they're experiencing sensory sensitivities. Let's say as they're getting scans done, do they like music? What kind of music? Disability identity, we want to be framing their identity and their preferred language in the medical chart, and when folks are using it with them, sensory likes, dislikes, and triggers, we'll get more into that in a couple minutes. We really tap into accommodations and strategies and learning, like, oh, if you have gotten care elsewhere, what worked well there or what didn't work well, so we can do better. And then care partners and supports, we want to know about any constellation of people who are supporting that patient. It could be family, it could be friends, co-workers, if they live in a group home staff. So we're thinking really creativity of like what that support network looks like and the person's preferences on who they want to include and how. Okay. So the next slide I'm going to show you is a graphic. Again, it helped my brain organize information as I was getting acclimated to an oncology setting, which was unfamiliar to me. I was really used to being in school, used to being in like an academic setting. So working alongside our advisory council members, we thought about the considerations when someone has IDD and they're coming in for cancer care on a couple different levels. So individually, again, some of this ties back into the assessment. What are their strengths? What are their preferences? What's the decision making? Then at an interpersonal level, we need to think about all the people they're going to be interacting with when they're coming in for cancer care. We need to be addressing ableism from the start, training up all the folks. So now we have a mandatory training for Dana-Farber that is on like disability affirming care. We do a lot of training or consultation with the different teams, and we think about communication and how we can be tailoring communication expressively, out loud, in writing, so that it is the best match for the patient. Diagnostic overshadowing, Jonathan touched on that, you know, earlier, that this happens where people will make assumptions that what a person's experiencing is because of their disability, is because of sensory sensitivity. When we're talking about cancer and it's multi-system, like we have to be really, really, really careful about overly attributing something to a disability. There's a lot more that's going on. Pain assessment, if any of you are interested in pain assessment, this is another area that like really needs to be worked on, making accessible pain scales, especially in the cancer world. We're trying, making modifications, but there's so much that can be done. And Jonathan has some cool stories about them too. And then really big picture is this whole system, the whole idea of the medical environment. So electronic health records, again, we just started a year ago asking about disability identity and accommodations. That's many thousands of patients who were not screened prior to that time. And so now that we have in the record, it shows if somebody has a disability identity, what's their preferred communication? What are their accommodations? That's a big change, but a lot of catch up that we need to do. Even accessibility in the building, still something to be working on. Sensory overload, the lights, the sounds, the smells, even the sensations of kind of coldness entering your body if you've got an IV with your treatment. Like there's so much when you're in cancer care, just on a sensory level, and time for appointments. We need more time with our people who have IDD to be able to meet with their providers so that the visits are not rushed and so that they're getting a really full workup. Health literacy, Jonathan will talk about in a couple minutes. I put in security here too. I don't know if you have experienced this, but there was also a lot of training to do with security around challenging behaviors when it's actually like a mismatch or communication breakdown, and what can we be doing to be proactive, help somebody feel as comfortable as they can be, help the team know that hand flapping is not aggression, that maybe hand flapping is excitement or is how they're processing this news that they're receiving. And then a lot of coordination with other systems, whether it's the Department of Developmental Services, National Center for the Blind, etc. So these are the kind of many considerations that we're taking into account and trying to figure out programmatically, in addition to individual counseling, in addition to the consultation, sensory modifications. How do we work within all these systems and make big system improvement? A couple more examples here of sensory sensitivities. So some of the things that are like really easy to roll out, and I wish that this could be done everywhere, around temperature. So having access to cool packs or heating packs or warm blankets or beverages of preferred temperature. And just because in cancer care there is a lot with temperatures, there's rooms that are freezing, or you've got to put on a Johnny and go in the machines. So we like to do a lot with temperature, with pressure, maybe a weighted blanket and something that's like really calming to have on you for a person who's having chemotherapy. Lighting, not always doable in some of the older rooms, but dimmable lighting, positioning. For some people, being seated and talking to the provider doesn't work, but being able to move around. For other folks, it may be reclining in a bed rather than having to be seated. We do get a lot of requests around noise. And so some of what we've done is trying to bypass the waiting area that can be really noisy. It can be distressing, especially to see people if they are outwardly looking very ill. And so bypass the waiting room, get into a private space where a person can use their coping strategies, noise canceling headphones, amplifiers for folks hearing, and then people, access to a support person, making sure that we can make that happen, calling in any folks. So much we can do with technology to get people virtually in a room, especially, and you're getting cancer information. It's really complex. It helps to have someone there that can be processing it as you're just in the moment, taking it in. A couple other things, making visual schedules, fidgets, audio recording. I'll leave it at that for now. And I think, yeah, you're up next. Back to Jonathan.
I'm back. So then, I have sensory integration disorder and experience a lot of sensory sensitivities during my cancer journey, and still do. Here are some accommodations that help me that perhaps might help you, help some other neurodivergent patients too. I prefer a countdown before receiving shots or having blood drawn to reduce my anxiety and help me mentally prepare for it. I bring my own equipment like headphones, sunglasses to medical appointments in case there may be a baby crying or a loud waiting room. And sometimes the lights are just too bright for me. I may need to pace around the room to process information. This helps me not to feel overwhelmed and helps me to process as well. And I also bring a Cookie Monster, this very one, with a real port in it. Don't ask how. And it's to all my visits. I use the Cookie Monster as a sense of comfort, and it helped me emotionally and sensory wise. I could feel where the port was, wherever it is. Just pretend I'm doing it right now. Where what the port was going to feel like when placed inside of my body. Now, let me tell you about Kayla. She wasn't just my physical therapist. She was an advocate who changed my life and really was one of the people that saved my life as well. When the doctor finally promised to figure out what was wrong with me, I was referenced to physical therapy, and that's how I met Kara. From the start, Kara treated me like a person, not a patient. She made me feel heard and valued, building that made me comfortable. Her care didn't stop in the therapy room. She even spoke up for me at an emergency IEP meeting at my school. Kara wrote a letter that ensured my therapy costs were covered so I could stay with her instead of being transferred to someone new. Kara's belief in me was unwavering. When my pain wasn't improving, she advocated for another MRI. My first attempt failed because of severe pain, not my autism, as the technicians assumed. Kara pushed for a second MRI, and when that didn't work, she supported me in requesting one under anesthesia. That third MRI revealed something life-changing, a rare cancer called Ewing sarcoma. Because of Kara's persistence, I was quickly referenced to Mass General Hospital and began treatments before the cancer spread further. Even during my cancer treatments, Kara stayed in touch, sending cards and encouraging me and my family. Kara didn't just treat my pain, she fought for me. She showed me that my voice mattered, that I deserved good care, and that I could trust someone in the medical field. Without her, we might not have caught my cancer in time. Kara's compassion, advocacy, and commitment to seeing me as a whole person made all the difference. She changed my life, and I will always be grateful for her and her belief in me. AGIs. Building trust and rapport with me as the patient is extremely important. How can I trust you with my life if I don't feel comfortable and understanding what you are going to do to me? When I first met my healthcare providers, I liked them to speak directly to me, then only communicating with my mom. My mom is my support person, and I am the patient. Even if I cannot not verbalize communicate it, it is important to talk directly to the patient while respecting the voice of the caregiver. This builds trust and relationships. When healthcare providers can adapt their communication to improve understanding and comfort, it makes it a much easier appointment. I believe for everyone. For example, I found the traditional smiley face pain charts confusing, but my nurse, Christina, adopted the scale based on how long I could play a video game. Nurse Christina took my interest and made an individualized medical tool for my specific needs so that I could better understand and communicate my pain levels. Nurse Christina did this through my cancer journey and continues to do it for me in my recovery. She uses my interest to break down the information so that I can understand it better. And you,
A hard act to follow. Yeah, I'm good. I don't know this. So I mean, this story is just like completely bring to life what it looks like when you can have person-centered, thoughtful care. And then on the flip side, what happens when, ableism digs in and is at play. A couple examples of additional literacy tools that we have been trying out at Dana-Farber is doing some color coding, picture coding, and medical stickers on the very confusing patient schedules. So I don't know about all of you, if you've ever had like a day full of visits, look at the printout and there's all these abbreviations that I'm not even told what the abbreviations mean, and there's tons of numbers. They could be like the barcode of a computer, and this is what you're supposed to be following for the day. So I have a number of patients, some of whom do come into Dana-Farber on their own and really pride themselves on independence, and the schedule doesn't make sense. So we've been trying to figure out how can we adjust the whole view of the schedule so you have the information that you need to know, you can get to where you need to get to, and it's a way that makes sense for you. And some of the feedback from our patients have been color coding with like the different levels on the building or different types of appointments. We've taken the camera around the campus to take pictures of what the different check-in areas look like and just print out those pictures, get those pictures on their individual schedule. And then if needed, people can also have a patient navigator or like human guide, somebody that can be with them, take them through the like labyrinth of the building. Audio recordings have been really helpful for folks with processing, with retaining that information. So it could be as simple as using a smartphone and getting that audio recorder or coming in with an actual separate audio recorder. We've been trialing out some QR codes as well, and QR codes that open up to say like a chemotherapy teaching video, because standard practice are these big packets of information. What's happening, what to expect, what to look out for, what to call the doctor. And for some of my patients who don't read, they need the information. How do we make this information digestible for them? And so teaching videos, not where you have to open up a phone and then be typing in the HTTP, but just have it open right up, open right to what you need to be listening to. We've done a lot of plain language stories. So again, taking these huge materials and just trying to bring it to an understandable language and also actionable language. What is it that the patient like really needs to know and needs to be doing, let's say for their treatment or follow-up. Patient navigator, yet for volunteer. And then a really key piece that I just like to hit home on, and I know that Lens is all about this, is co-creating with members of the disability community and having that be just integrated throughout. So I was so pleased, like Jonathan and I met through the ARC. In some way we got connected.
Yeah, in some way. I think, was it Operation Housego?
That may have been, initially I was trying to find like who's out there, who's been through cancer, has developmental disability, is open to talking to me. And Jonathan was very open to talking. So like he was treated at a different cancer center and has so much knowledge that is like really going to transform what cancer care looks like for people everywhere. So you've got to build in ongoing opportunities, not a once-off, not at the end, oh, here's what we've designed, what do you think? But like from the start and throughout. Okay. I have our contact information in here because we do want to share resources with all of you. So my email's up here. Jonathan's email with the ARC is also listed here. That if you have ideas, if you want to talk further, you're welcome to be in touch with us at any point. Thank you. Let me just show you a couple more slides and then we'll take a little break, and then we have some cool breakout activities for you all to think about how you would support a cancer patient or family member, depending on what perspective you want to take. But some resources, just want to highlight Disability Equity Collaborative. If you are someone who's really interested in the electronic health records and making big systems improvement, national improvement, they're amazing, and they have ongoing calls that you can just log into and hear about what people all over the country are working on and improving all that disability identity and healthcare. Operation House Call.
I can do it.
You want to talk about that one?
Well, I am the ambassador, so I might as well promote it.
Go for it.
Operation Housego is where people with disabilities go in and teach up-and-coming medical students how to treat people with disabilities. Let me see what other stuff you
Yeah,
have.
you got it.
So that way we can all have a fair and equal treatment of healthcare. Yeah, I think that covers
Awesome.
that.
Yeah. So I've also been looking at like, what does Operation House Call do? Because there's such great work that's out there. It just often it feels siloed, and in the cancer world, this doesn't exist anywhere else. So we're trying to figure out what can we be replicating, how can we partner with agencies who are doing this, doing an amazing job. The National Roadmap for Disability Inclusive Healthcare. I don't know if any of you have seen this yet. It's an amazing resource. So check this out. It's cool for any kind of healthcare, not cancer specific, any kind of healthcare. I also have to give a shout out to One Idea Per Line because I really learned so much when it comes to making easy to read, plain language, social stories, and that's by the Autistic Self-Advocacy Network. So they do really cool stuff as well. And then there's too many citations to name, but if you want to read more, it's in there. And then, yeah, we'll pause here, take a little break, and then we'll do our breakouts.
So can I share with the online people? During the break, Melissa's gonna log in and put a case study into the chat for you guys to talk about when you do your breakout room. So look at the chat when you come back. What time do you want them back?
Oh, 11 o'clock, does that work, Melissa?
Yeah, that should work. That gives us a couple minutes to get it all up.
All right, take 8.